Hello, so today we're going to talk about women's health, and this is a really big topic, so it's just going to be the basics today. So the aim of this lecture is to describe and treat common minor ailments experienced by women, and the point of this is so that when you go into a community pharmacy, you'll be able to give the right advice and select the right treatments for people that come in with these kinds of conditions. So by the end of this lecture, you should be able to describe what these conditions are, and we're covering many of them, but actually not all of them. Explain causes and symptoms, recommend treatments, and identify situations that require referral. And so with this information, this gives you the basics to be able to cope when you go into a community pharmacy, but you'll also get some more information in your third year on this subject. So the lecture is split into 4 parts, and the first one is about menstruation. I'll just give you the basics on that and then conditions associated with it, and that's what we're doing now. And then we've got infections, pregnancy, and then older women. So looking at the menstrual cycle and the female reproductive tract, so you should know about this all already, unless you didn't do biology. So if you didn't do biology, then I would suggest that you get a physiology book and just refresh your memory on this. And again, this is one of the subjects that you'll go into in much more detail in your third year in a lecture that you get then. But just very quickly to go over things so that you can refresh your memory and think about what's going to happen in this lecture regarding menstruation and the problems associated with it. So for the female reproductive tract, you've got ovaries, which produce eggs. The eggs travel along the fallopian tube here, and then they end up going into the uterus or the womb. The lining of the uterus is called the endometrium, and then this has a passage to the exterior through the vagina. So what you have with the control of the menstrual cycle is controlled by a series of hormones, some of which are produced in the anterior pituitary and the others within the ovary. And this allows for the sort of monthly cycle and the release of 1 or 2 eggs or even more per cycle, but usually 1. And so you've got your cyclical hormonal control, and as well as the cyclical hormonal control dealing with when the ovaries produce and release an egg, they also deal with preparing the endometrium for implantation of that egg. So you get a gradual thickening of the endometrium depending on the time of the month, and then at the end of the 28-day cycle you get degeneration of that thickened endometrial lining, and this is what menstruation is. And blood then passes, blood and its cells pass then from the uterus through the vagina to the exterior of the body, and this is menstruation or periods. So some conditions are associated with that, and one of them is dysmenorrhea, which is commonly known as period pains. Up to 1 in 2 women suffer, so you can see it's really common, and some have to take time off work because it's pretty, it affects their life quite a lot. So up to 1 in 10 take time off work. The symptoms start just before menstruation and then can last up to about 72 hours, so 2 or 3 days. And they're basically pain, it's abdominal pain. You can have lower back pain, and you can also get pain down the thighs and legs. Abdominal cramping and bloating is very common. You can get nausea and vomiting and some other symptoms as well as seen there. So there have been some studies to find out whether there are any factors which predispose women to dysmenorrhea, and what they've found is that it's much more likely in people less than 30 years, and actually quite often it starts soon after the menarche, which is when the periods first start or when menstruation first starts. And low or high body mass index is a reason for having dysmenorrhea. So if you've got ideal body weight, you're much less likely to have it. Smokers are more likely to have it. Those that have an early menarche, so they start their periods early, at less than 12 years old. Those with psychological symptoms, so people who've had maybe sexual abuse and they maybe link their periods to unpleasant things that have happened to them. Longer cycles, so those who have a longer than a 28-day cycle, which is the usual, and those with nulliparity, and what that means is that women haven't had a baby. So you can see from a couple of these factors, predisposing factors, that you can actually reduce the chances of having dysmenorrhea by healthy living, because you can get your body mass index to an ideal weight, and you can also stop smoking, and that should reduce your chances of having it. So there are two types of dysmenorrhea, primary and secondary. In the community pharmacy, you will only be dealing with and treating people who have primary dysmenorrhea. Those with secondary dysmenorrhea need to be referred to their GP. And so we've got to be able to differentiate between the two, and hopefully by the end of this lecture you will be able to do that. So primary dysmenorrhea is where there's no underlying pelvic pathological cause. It's basically a normal part of going through the menstrual cycle, and it's related to the endometrial release of prostaglandins and leukotrienes, and this is a normal part of the cycle. Levels are increased, and people that end up with dysmenorrhea are probably more sensitive. So it's very common in people aged sort of 15 up to 25 years old. So as I said before, it usually starts within the first year of the menstrual cycle and can continue for a decade or so thereafter for people that suffer from it. Secondary dysmenorrhea is quite different in that there's an underlying pelvic pathological cause, and it's more common in older women between the ages of 30 to 45, so these women need to be referred. And so what we have to do is to ask the right questions to figure out the difference between these two types of dysmenorrhea. Secondary dysmenorrhea can be caused by a number of conditions, and I'm just going to go through those so you understand the sorts of things that can happen to cause it. So dysmenorrhea is abdominal pain around the time of the periods, and one cause of that can be fibroids, and these are benign tumours which grow in the uterus. And 40% of women have these, so it's very common and not necessarily harmful, but what it can cause is secondary dysmenorrhea. We've also got endometriosis, and this is a condition where at the time of menstruation, cells from the endometrium, which are still living cells, sort of backflow up the fallopian tubes and end up in the abdomen. And these can then adhere to the outside of the uterus and to other organs. And every time, thinking about the hormonal cycle, those cells are still alive, and what happens is they proliferate during the cycle, the same as the endometrial cells within the uterus. And then at the end of the hormonal cycle, when you've got reduced levels of estrogen and progestogens, those cells then start to die off. They shed, they then bleed just the same as the cells within the endometrium. And so what you end up with is cyclical bleeding within the abdomen rather than within the uterus. And so that causes a lot of pain, and that's what endometriosis is. And so you've got this cyclical situation where you've got bleeding within the abdomen outside the uterus. So pelvic inflammatory disease is another cause. So this can be where you've got inflammation of the female reproductive tract, and that's because of infection, usually something like gonorrhea or chlamydia, and this can cause pain during menstruation. And then you've also got the insertion of intrauterine devices, IUDs. These are inserted, usually a sort of T-shaped thing like this at the bottom here, which is covered in copper. Usually the copper coloured ones are the ones that cause dysmenorrhea, but it can also be ones that release progestogen. And these are inserted into the uterus for contraceptive reasons and left there often for years, and they can cause secondary dysmenorrhea. So you'd want to refer anybody that you suspect has any of these conditions. There are other conditions which you might need to eliminate as well. The person who comes to see you may have symptoms around the time of their period, and so they may be sort of swayed to thinking that it's dysmenorrhea. So the symptoms of acute appendicitis might occur at that time, and this is where you've got obviously inflammation of the appendix, and that would just be pain on the right hand side, so one-sided pain. Ectopic pregnancy, this is where you've got an egg that implants, a fertilised egg implants in one of the fallopian tubes, and this can cause pain, and again it would be one-sided pain, and there might not be any bleeding because you've got a blocked fallopian tube, and also you've got a fertilised ovum which is implanted, or there might be loads of bleeding because it's ruptured. So somebody may confuse that with dysmenorrhea, but it would be quite a severe condition, and it's actually in a medical emergency for somebody with an ectopic pregnancy because it can rupture the fallopian tube itself. Inflammatory bowel disease, so this is Crohn's or colitis, ulcerative colitis. These conditions, you would usually get pain at other times of the cycle as well. So it wouldn't be something that's specific to the cycle, but somebody might confuse it if it starts around the time of their period. Irritable bowel syndrome is the same. So this is where you've got irregular contractions of the intestines, and it's a very common condition. And so that can also be confused because you get cramping and abdominal pain with that as well. Urinary tract infections, again, if somebody gets one around the time of their period, they may get it confused, but we'll go into that a bit later. And of course, tumours. So some people do end up with tumours of the endometrium or other parts of the female reproductive tract, and the symptoms may get worse around the time of menstruation. So how are you going to separate out these serious conditions versus just primary dysmenorrhea, which you can help the patient with? So what you need to look for is pain or bleeding between periods. So it's thinking about it being specific to the time of the periods, or pain or bleeding after sex or urination. Sudden severe pain, so that might be an ectopic pregnancy. Pain on one side, again, ectopic pregnancy or maybe appendicitis. Fever, if somebody's got a high temperature, they may well have an infection as well. Amenorrhea or severe menorrhagia, and we're going to talk about menorrhagia next, and that's heavy bleeding. Amenorrhea is when you've got no bleeding, so either of those situations would be something to refer somebody. An unpleasant discharge from the vagina, this might be because somebody's got an infection. IUD insertion. Painkillers that have been tried for 3 or 4 cycles and they're not working, so whatever we've tried over the counter already doesn't work, so then you would want to refer. And you would also want to refer anybody that's a bit older, that's got these conditions, with pain of the abdomen around the time of having their period, and it's the first time that they've had that. This is the information that you're going to need to make your diagnosis as to whether it's primary dysmenorrhea or not. So you need to know, when did it start? So if it starts at or just after the menarche, which is when periods start, then it would be primary dysmenorrhea. If it's years and years after when periods started, then it's less likely to be primary dysmenorrhea. When in the cycle does the pain occur? If it's within 24 hours of menstruation and it lasts for a couple of days, then that's going to be primary dysmenorrhea. And if it's occurring at different stages of the cycle, as well as during periods, then it's more likely to be secondary dysmenorrhea. So are there any other gynecological symptoms? If not, then it's primary dysmenorrhea. If there are, such as this bleeding between periods or having pain after sex or during sex, then that's not going to be primary dysmenorrhea. And if somebody's already tried treatment such as non-steroidal anti-inflammatories and they've got a good response, it's more likely to be primary dysmenorrhea. And if you're going to ask your WWAM questions, then you need to ask a few extras basically, because they're not going to cover everything. So just to make sure that you ask, how long do the symptoms last and where are the symptoms in the cycle? Are they just around the time of the period, or do you get symptoms at other times as well? So that's an important thing to ask. And also you need to know, has the person got an IUD or a coil inserted? And when you ask what are the symptoms, you're going to need to know all those extra symptoms and maybe ask and be a bit more probing. So what WWAM doesn't give you all the things that you need. So the treatments, so for this primary dysmenorrhea, so mostly non-steroidal anti-inflammatories are going to be your mainstay, because of course this condition is caused by prostaglandins, and so your non-steroidal anti-inflammatories are cyclooxygenase inhibitors, and they prevent the prostaglandins from working so effectively by inhibiting their production. So you've got ibuprofen as a mainstay, and then you've also got naproxen, which is specifically for dysmenorrhea. That's the only licensed over-the-counter use for naproxen, and so either of those are available. So if you can't give non-steroidal anti-inflammatories to a patient because they're contraindicated, either, and the reasons for that can be many, and I hope you've had some lectures on these. So the reasons that somebody won't be able to use non-steroidals might be because they've got asthma and they respond by getting wheezy, or they get GI side effects to non-steroidal anti-inflammatories. Maybe they've got a gastric ulcer, or it might be because they have heart disease, renal disease, and you must never assume that just because somebody's young that they might not have those conditions. They do need to check. If they can't have non-steroidal anti-inflammatories, you can give paracetamol. You can give products which have codeine in them, so we can't just give codeine over the counter on its own as tablets because it's prescription only medicine, but it is contained within cocodamol, and also ibuprofen and codeine mixtures as well, which you can give for this condition. We've got also dihydrocodeine with paracetamol, which you can supply over the counter as a P medicine as Paramol. And you've also got hyoscine, which you can give, which is specific for cramps, because that's an anticholinergic and it relaxes the smooth muscle of the intestine, reduces cramps. So other advice you can give, well, certainly as we said before, you can talk to people about their smoking status and see whether they want to stop smoking, aim for an ideal weight, and then you've got other things. So exercise helps by reducing releasing endorphins, which then helps with pain. A lot of people use heat, so they might use a hot water bottle, and we've got products such as this Cura Heat pad. There are various other heat pads which you can give to apply to the abdomen to relieve things a bit, and then other things you can do, having a warm bath, that kind of thing, relaxation techniques, TENS, and actually oral contraceptives can really help with dysmenorrhea by controlling the cycle and those hormones which are causing it. And so if somebody's tried all of these things already and they don't respond very well to the treatments over the counter, you refer them. So I've got a case study here for you to have a look at, so just have a quick read. Okay, and then a few questions for you. So what is the diagnosis? So is it going to be primary dysmenorrhea or secondary dysmenorrhea? Well, thinking about that case, this is somebody that's had symptoms between their periods, not just around the time of their period. So it will be secondary dysmenorrhea. And what is the cause? And of course, we don't know what the cause is, but what we could say is that it could be any one of these conditions. Probably quite likely for somebody in their 20s to have endometriosis, but we don't know. And of course, you wouldn't say that to the patient. You would refer them to the GP for investigation so that they can find out exactly what's wrong. And what treatment would you suggest? Well, if it's secondary dysmenorrhea, then we're going to refer. Okay, then going on to the next condition, which is menorrhagia, also known as heavy periods. And this again is very common. So 30% of women have it. 5% of women between 29 to 44 will consult their GP about it. And bleeding increases with age. So as you get further on into having periods and think you're going to have them between the ages of 12 and possibly even younger, some people start even down as young as 8 years old, and then they're going to be going all the way up to being somewhere between say 45 to 55 years old before their periods stop. And as you get older, it gets worse. So this heavy bleeding or heavy periods is subjective, but clinically it's defined as excessive menstrual blood loss which interferes with the women's physical, emotional, social and material quality of life. And in this box at the top, are some of the things that people might come in and say to you. They might say that, oh, I just, constant bleeding, I have to change my pads every couple of hours, can't go anywhere, can't sit in the car without bleeding through my clothes, all that kind of thing. So listen to what people say to you, and if it's affecting their life so that they really struggle to go out anywhere, get to work effectively without having to really worry that they're going to bleed through their clothes, then that's heavy periods. And the amount of blood that is actually lost is very variable. So some women will lose only 50 mils for their whole period of menstruation, which might last, between a couple of days to a week. And other women may lose up to 500 millilitres, and you think that's 6 litres over a year. So very variable with the amount of blood loss, but also it's a subjective thing in that people perceive it as being something that really affects their life, depending on their whole life. So menorrhagia, as you can see, I think that picture at the top really says it. So menorrhagia, for most people, there's no known cause, and it's just known as dysfunctional uterine bleeding, as in you're bleeding a lot, but there's not really a physical cause for that. It's just part of menstruation. So that's the majority of people. But there is a gynecological cause for the other 40 or so percent, and we need to make sure that we understand the reasons for it so that those people can be referred to be investigated. So that could be things like pelvic inflammatory disease, we talked about that, that's due to infection, a tumour, polyps, so where you've got little growths in the uterus and those can bleed. You might have fibroids, which bleed more when there's menstruation, but they might bleed also at other times. And endometriosis, as discussed below. And then also things such as having clotting abnormalities. So somebody might have a problem with the clotting cascade, with the clotting factors, and so then they're bleeding more often. So of course anything gynecological, endocrine or haematological should be referred to the GP for assessment and treatment. So red flags. So what have we got? So irregular or postcoital bleeding. Postcoital bleeding is when you've had bleeding after sex. So this is bleeding between your periods as well as at them. And if it's really heavy bleeding, then somebody should be referred. If anemia is suspected, so somebody who's losing that massive amount of 500 mils every month may have developed anemia and they need to be referred. A recent increase in blood loss, which is different to normal, should be referred. There might be some condition there, such as a tumour that's just started to bleed, and you would need to refer somebody. Other symptoms, pain during intercourse, pelvic pain, vaginal discharge, fever, all of these things indicate some secondary problem involved. And then you've got somebody on anticoagulants or antiplatelets, so anybody on those drugs, they need to be referred because they might need to have their drugs changed. And also, if tranexamic acid, which we can supply over the counter, is not suitable, then we would also need to refer. And I would also add to this list that older women, although older women generally have heavier periods, quite often they also have gynecological conditions appearing, such as fibroids, and they would need to be referred so that they can have an investigation. So tranexamic acid is the treatment that we can supply over the counter, and I've put the Boots brand there, which is Cyclo-F. The mechanism of action of this, it's an antifibrinolytic, so a competitive inhibitor of activation of plasminogen to plasmin. So basically it's stopping blood clots from breaking down. So if you go back to your clotting cascade lectures, you'll understand that. It's stabilising the clot basically. And clots stop the blood vessels from bleeding within the endometrium and so reduce bleeding. So it can be used to reduce menstrual bleeding for people aged 18 to 45 who have regular cycles. And there's a dosage there, I don't expect you to remember that. But it's contraindicated to give this to a number of people, and one of them is those with current or past thromboembolic disease. So this is people who've got a problem with blood clots anyway, you would never want to give them tranexamic acid because it was more likely to induce them to have a thromboembolic event. Hematuria is blood in your urine, and you don't give it to people with that. Irregular menstrual bleeding, so this is where you've got some other gynecological cause of the menorrhagia, and you want to make sure you don't give them this, which may help to stop their bleeding but will mask whatever's causing the problem. So anybody on warfarin or other anticoagulants, and so they're probably people who have thromboembolic disease, because you'll reverse the effect of their anticoagulants, give them a blood clot and might give them a stroke. And people with renal insufficiency, and that's because that's how the drug is metabolized. So you'll also need to check, they will need to check with their GP if they're taking tamoxifen, which can cause blood clots. Oral contraceptives, again, it can be something that induces thromboembolism. If somebody has a family history of endometrial cancer, because that might be the cause of their heavy bleeding. And also for people who are obese or diabetic. So those people can't take this drug. Okay, so we've been through several conditions there, menorrhagia and dysmenorrhea, and thinking about menstruation, and there's a whole mass of medical terms associated with that. And if you're going to go and work in a community pharmacy, GP practice, or in a hospital, then you need to know the medical terms for these things. So just to go through, you need to think about periods are known as what, and begin at which begins at 12 years of age. If you just read through and try and figure out the words that fit into this to begin with, and then the next slide will show you the answers. Okay, so periods are known as the menstrual cycle and begin at the menarche, which is usually around 12 years of age, but as I said, it can be as young as 8. The lining of the uterus is called the endometrium. Symptoms of painful periods are called dysmenorrhea. Heavy periods are termed menorrhagia. And what is it when a woman has no periods? That's amenorrhea. And I don't know whether I discussed this, but the menopause is when a woman stops having periods, usually around 45 to 55 years of age. Okay, so then quickly going on to premenstrual syndrome. So this is another condition associated with the menstrual cycle, and it's some physical and mental symptoms, and the incidence is related to the menstrual cycle, and it occurs at the same time every month during the menstrual cycle, and it's up to 2 weeks before day 1. So day 1 is the first day of menstruation, and once you have menstruation it gets much better, and it's caused by ovulation. So ovulation usually occurs around day 14 of the cycle, if you go back to the menstrual cycle picture right at the start. And so around day 14, ovulation starts to trigger these symptoms because women may be more sensitive to progesterone, which is starting to get into high levels at that point. And the high levels of progesterone also lead to a reduction in the neurotransmitter serotonin, which can affect mood. So it's all these things together, and obviously a bit individual for the symptoms. And just to say that the physical symptoms can be very varied, and you can see all the different things that can happen there. And you know, sort of bloating, weight gain, nausea, headaches, all of those things. And then you've got psychological and behavioural symptoms associated with mood as well. So the physical symptoms are often associated with high levels of estrogen and progesterone, which occur for that second half of the menstrual cycle. And then the psychological and behavioural symptoms are more likely to be related to the low levels of serotonin. So there's also a much more severe version of premenstrual syndrome, which is premenstrual dysphoric disorder, PMDD. And this is much more severe psychiatric symptoms. And again, it's going to be cyclical because it's related to the cycle, but it can really disrupt the life of the person that has it and ruin their relationships. So with these cyclical symptoms, which again will be starting about 2 weeks after the first day of the menstrual cycle, day 1, first day of bleeding. And as you can see, suicidal ideation, feelings of hopelessness and depression, and this is due to low levels of serotonin. Obviously, the people that get this are very sensitive to that, and you must refer people. Quite often they're treated with oral contraceptives, or they might be given antidepressants to deal with this. And then just to think about the treatments that we can do for people with premenstrual syndrome, so the less severe variety. So what we can do is deal with some of the symptoms. So for pain, we can give non-steroidal anti-inflammatories or paracetamol. So we can also give buscopan cramps if somebody's got abdominal cramps. And then also there are lots of other things that people like to try, but whether they have a real medical benefit is debatable. Trials don't really show that. But what you can say is that people can give them a try as long as they're not harmful. So people can change their diet, reducing caffeine and alcohol seems to help, or sometimes having small and regular meals if people are feeling bloated. And then people try other things such as pyridoxine, which is vitamin B6, up to 2 mg a day. They can try evening primrose oil, calcium, magnesium and herbal remedies, and of course exercise always helps by releasing those endorphins. But really the holistic ways to treat, as I say, there's not a great deal of evidence, but people might sometimes want to try them. I might discuss it with you.